Dr. Webb, along with Bruce Nairmore, who's the Chief Financial Officer. As you know, Dr. Webb is the Chief Executive Officer. And Dr. Webb, you have the floor. Oh, and the presentation that Nashville General has, it has been uploaded to the Council Resources page, so if you want to pull that up and follow along, you can.
All right. Well, thank you, Council Lady, and it's good to be back, and brings back some fond memories. So it's good to be back in front of the council to speak about Nashville General Hospital and the things that we're doing there in this budget year. As you know, I'll start with the first page of the presentation. That the charter, Metro Charter, does require that the city operate a hospital to provide care for Davidson County residents who are indigent, as well as others that are uninsured. And Nashville General has provided that service now for 131 years, including, as the notes state, the last 27 years on the campus of Mahari Medical College. I want to thank you, the council, as well as administration, for the recent capital that we were afforded at Nashville General Hospital, right at a little over $1 million. We were able to purchase some much needed capital equipment. And one of the things that plagues us oftentimes is having to utilize operational dollars to purchase capital equipment, particularly major capital equipment. That becomes a real drain on our operational budget funds. So thank you for that. And moving into just some clarification as to why we are where we are with our budget and our budget request, just some justification for that. In 2017, a previous mayor made an announcement regarding discontinuing some major services at the hospital, which caused a large number of our clinical and physician providers to leave the organization, as well as Mahari Medical College. We relied on those providers, the ones at Mahari Medical College as well, to provide services, key services to our patient population. And when they left, we had to move into hiring and recapturing a population of physicians that we had to hire in order to provide those services, basic services, nothing extraneous, but just the basic core services to our patient population. Now that we've done that, this is a source of some of the additional funds that we're requesting in our budget. With the added providers, though, we are also looking at projected costs, revenues to offset those costs. So, but there is some lag to that, as Mr. Nairmore will further elaborate on. We've added also a clinic on Charlotte, which assists us with attracting individuals, patients. Particularly, we're seeing a number of our Metro employees. So it gives us more insured patients to help further offset some of the costs of the services that we provide. The self-generated revenues, as you'll see in the presentation, are projected to be up by 27% in the 2 years, over the next 2 years. So now, also due to COVID and some of the effects of COVID, we saw a sharp increase in costs associated particularly with labor. And as you might imagine, already seeing a nursing shortage across the country, that was exacerbated by COVID. Those numbers went up exponentially, particularly as it relates to the travelers and the contract labor that we were exposed to. So some of that, even though we're on the downside of COVID, there will be some residual. Vendors tend not to just move away from those high costs suddenly once they've gotten there. So we'll see some residual there. So in summary, I will say that the increase in the budget funds that we're looking at is largely due to covering the cost of the provider base that we've brought on, which is an excellent group of physicians, and also some unanticipated increase in costs that are associated with the COVID. The growth of our provider base and the additional percentage of insured patients will generate growth in revenues that are collected, and it will help offset the subsidy as we go forward. This is what we will expect to see. So at this point, I'm going to turn it over to our CFO, Mr. Nairmore, to walk you through more of the information. Now, if you have any questions for us, please don't hesitate to let us know.
All right. On page 4 of the presentation, there's just sort of a breakdown, because I know we've got a mix. This is my first time for some of you. I know some of the council people here, but some of you may not have the history that others do. So I just wanted to sort of, on page 4, there's just an overview of the sources of revenue that make up the budget for us. The first one at the top is our own self-generated revenue from taking care of patients in the hospital, $49.2 million. Then there's other government funding, and this is funding that was at risk if the hospital ceased to be an inpatient hospital. So we get about $10.5 million a year from the supplemental pool with the state because we're a safety net hospital. Metro provides roughly $4 million match, and then we draw a $10.5 million amount from the state. Then we have some other monies by virtue of the patient load, uninsured patients that we take care of. Disproportionate share for low income is about $3.3 million. We get about $800,000 a year for graduate medical education for the residents that train at the hospital. And then we have Medicare bad debt reimbursements for our true Medicare patients at roughly about $2.4 million. So all in, we generate a little over 60% of our revenue, at least in the 2022 budget. And then the subsidy that we requested was 49.56. And so I think a lot of times people think that this hospital is 100% funded by the city. While we're very appreciative and it's important that they fund the hospital, the majority of our support actually comes from our own sources. And we move into, I think Dr. Webb mentioned on page 8, there's a brief description of some of the providers that the hospital has either employed or directly contracted with. Most of that was the fallout from previous mayors' at least announcement that the inpatient services would close. Mahari probably lost, I don't know, last count it was around 30 physicians that did significant care at Nashville General. And Mahari has replaced a good number of those physicians, but they've also ceded to the hospital a couple of areas particularly important: cardiology, orthopedic surgery, urology. And then we've added general surgery. Mahari still has general surgery. We've added some because we need at least 4 to take call for the hospital. We've added several primary care physicians out at the Charlotte location and locally at the hospital to increase primary care availability. We also brought on a gynecologist to work out at the Charlotte clinic, not OB, but just gynecologist that works out there. And we added an ear, nose, and throat mid-level provider, and we actually have 2 providers in ophthalmology, which was a service many years ago that was provided by Mahari, but for the last few years it's been a direct employment relationship. We have an optometrist and we have an ophthalmologist, a retinal surgeon who works at the hospital. So those are the costs that we've taken on over the last 2.5 years just for providers, not their support staff, about $6.7 million. But those are investments, and it improves access to care, and we are a hospital at the end of the day. And we work closely with Mahari Medical Group and the college. Unlike sometimes you read in the paper, we get along well when it's taking care of patients and we know what the goals are. I'm on page 9, just a brief look at the 5-year subsidy that had been provided through council and through the mayor's office. And you can see, and it's high in the year back when the supplemental of $17 million was needed to keep the hospital operational. It's gone down progressively back to 43 and 43. And then this year, with the issues that we're going to talk about briefly, it's up to 49.6, still below the high mark. Then we'll move back, moving on to page 12. Talks about COVID impacts and responses. Back when the pandemic actually started in February, we had seen very close to what we had budgeted, about a 10% year-over-year growth in terms of inpatient and outpatient volumes. But once COVID hit the hospital with the emergency declared, our ER volumes dropped about 35%. We had our clinics and our surgery and elective areas of the hospital actually closed for about 3 weeks. Some were a little bit longer than that. And even today, and I know today, I'm literally this past month of April, our ER visits are still down about 25% from where they were pre-COVID. And 75% of our hospital admissions come through the emergency room. So it's slowly coming back, but we're still seeing depressed volumes. So are other hospitals in the market. It's not peculiar to Nashville General. People are just staying clear of elective work. And if they have low-grade issues, they're seeking out either urgent cares or perhaps their physician offices. And then also, once protocols were established in the area, we've had to add screeners. So everyone, if you've entered the hospital in the last several months, you would see that everybody gets a temperature scan and a check before you can go into any place except the emergency room at the hospital. That's still in place today. We hope it'll wind down within the next 30 days or so. In response to the COVID crisis, we instituted a COVID hazard pay. Dr. Webb mentioned that we had a lot of nurses, frankly, and even respiratory therapists left Nashville or left the market to go chase jobs in other parts of the country that were paying extremely high rates of pay. And so we had a lot of gaps in the hospital. So before we lost more, we instituted what we call hazard pay. And it varied, but it was around $4 an hour for our RNs, I think $3 for respiratory therapists, and less for our EVS staff, so environmental services or food service, people that were working on the hot floors. Hot meaning they had COVID-positive patients or rule-outs on those floors. So all those staff were incented to stay on with the hospital, and that ended April 1st. So we've ended the hazard pay as of April 1st because we're able to get most of our staff back into the hospital. And we also had, I'll just say, we had, I'm sure the city had the same, we had many staff and many of our own physicians that contracted COVID, and so they were out for relatively long periods of time. We paid admin pay for them when they were out, so not sick pay, but admin pay. It's an eligible reimburse from the CARES Act funds. Dr. Webb mentioned the other big impact is just rates. We probably have about the same number of contracted hours for nursing in the hospital right now, but the rate of pay that's required to bring them in, I mean, it was $66 and $73 for a med-surg nurse and an ICU nurse. In April, it was $120 for an ICU nurse. So same resource, the price had gone up 65%. And that's if you wanted to have it. Your other alternative is closed floors or closed beds. And when you've got people that absolutely needed care. The case mix of the patients we were taking care of in the hospital was extremely high for most of the time of the sort of the COVID crisis seems to be settling now. Recently, the rates are starting to drop back down. I think I signed some med-surg ones this week that were $80 an hour. Not quite to 72. They bopped back up from 72 to 80 recently. It's supply and demand with the agencies. We have been able to backfill a lot of the spots and reduce contract labor. We have a pretty large group of new grad nurses coming on June, but that's 8, 10, 12 weeks before they really can take care of patients one-on-one. But that's definitely in process. On page 14, and 15, just a little review of the CARES Act dollars that the hospital did receive. Back in April timeframe, mid-April, we received 2 small grants totaling about $835,000. And then the big one was $9.4 million received mid-June. And all of the funds were restricted funds. I had to go in and attest that we would only use the funds for the excess costs of caring for COVID patients, not just your ongoing costs, and for negative or lost revenues, which was a significant impact for not just our hospital, but the other public hospitals. So we could use the funds to backfill dollars that were lost because of volumes, and we have. So we could pay for those hazard differentials we talked about, but we couldn't pay for Dr. Webb's salary or anybody who's just a regular employee at the hospital if they were there before and after. We could pay for protective equipment. That was clearly there. Supplies, pharmacy treatments like remdesivir and those sort of items, those were eligible. We just had to capture them all, and we've been doing that since that time. So then the slide below that, you'll see, you can just sort of see the incoming. That's the first 2 grants that came in, and then the big one that came in mid-June. Total was 10.275. And then the dollars that we claimed in fiscal year 2020 that was just audited, 2.6 million roughly in terms of lost revenue for that February to June. And then from July till April, you can see $3.2 million of net revenue impact. And then the expenses below are actual supplies or COVID differentials and so forth that were eligible. So as of April 30th, we just closed the month of April, we have only $224,000 remaining from the CARES Act funds, so we do think we're going to exhaust it before. And ours is, it ends June 30th, so we have to expend the dollars by June 30th. I don't know what Metro's own requirements are, but for the hospital dollars, they were able to be spent through 6/30 of 2021. There was also an alternate care site at the hospital, just you may have heard about it. The nice part for us was that they rented space on the 8th and 2nd floors of the hospital. The state did, and they paid us a rent of $70,000 a month. That lease ends May 31st, so they've been taking their items out of the 8th floor and 2nd floor. And the bad news is, of course, I thought it was well done, well put together by our chief medical, Dr. Bullock, and our chief nurse, Veronica Elders. Did a really good job of putting that thing together, and I think the state was very impressed with what we had. Thankfully, it never had to be activated. They never chose to actually activate it. The bad side is that I have an $840,000 hole in my budget because that money will not be paid. The construction for the site, I know it was in the papers and so forth, somewhere between $4 and $5 million. It was not our money. The state actually paid that money and apparently reimbursed through FEMA. But the ACS is closing. We will lose that rent revenue. And they made modest improvements to the 8th floor of the hospital, but they're not patient rooms. So they're basically, for you that are old like me, what a ward in a hospital used to look like. So there are 4 beds, but they're like dormitory beds, not patient beds. And then 1 bathroom, 1 significant size bathroom, so 4 share 1. And that's basically how they outfitted the 8th floor of the hospital. It's very nicely done, but it does not meet acute care criteria. I can't use it for anything in the hospital other than maybe the flooring and the fact they built these oversized bathrooms. So people have asked, is there any value to the hospital? Not really. In terms of what they left behind. The 2nd floor, basically they just created a divider so they could create negative pressure on that space. They pulled that out. That 2nd floor is basically back into normal use for us. And it was a noble exercise, and happily it was never officially open for care. So in terms of sort of big high-level budget impacts this year, and when you look at the 2022 budget, in 2020, our patient collections, in FY 2020, our patient collections fell from 41.7 to 38.7. This year, I'm projecting that's going to be 46. So It's almost $8 million increase this year over last year. And then next year, I'm projecting again a growth of about 3.1 million. That's the 27% increase that Dr. Webb alluded to earlier. So we are generating, even compared to a good year this year, an additional $3.1 million in self-generated patient revenues. On the cost side, all the physicians that we've added over time, the ones that we brought in part year, and of course, unfortunately, they were affected by COVID, so their patient volumes were much lower than they would have been traditionally. So it's just delayed the time for them to sort of get up and running and build their patient bases. But just the year-over-year salary increases for providers is about $2.4 million impact to the hospital budget. The remainder of salary increases is just a 3% COLA that we have budgeted for our own staff. And just for clarity, the hospital has a COLA. We don't have steps. We're not part of the Metro system, so people talk about that sometimes. We don't have steps. We just have a COLA when it's granted. The other big impacts are just supply expenses. We're double-digit in most of our medical supplies and pharmaceuticals, extremely high. We averaged a little over 10%. So we're forecasting a 5% increase next year. That it is based on our group purchasing organization has suggested between 5 and 8% for medical supplies. I tried to keep it low because I know, we were coming in asking for a big number. We're going to manage as best we can to those numbers. And the biggest impact to the budget, obviously, is there's about $7 million of CARES Act revenue and expense offsets. That'll all disappear. We don't have, the hospital has not been notified or alerted to any funds that would be made available to hospitals or to safety net hospitals like we did last year. I know some of the states and cities are getting some COVID or CARES Act fund, but the hospital is not aware of any. So that's a $7 million hit to our budget. And then just so everybody is aware, and I know Council Lady Suarez in the audience, we did execute the PSA with Mahari, which was an extensive negotiation. It does not have any dollar impact, but just for everyone to know that that's in place for 2 years, and that's a good thing for us. Questions?
Professional services.
Yeah, I'm sorry. Our professional service agreement with Mahari basically allows us to buy physician services from their physicians, not just their residents, but they have faculty that provide care in the hospital as well. So the arrangement is we pay basically Medicare rates for uninsured patients that the Mahari Medical College physicians see in the hospital setting. That's been long in place. It's not new. But getting it just re-up for 2 years was important. And I appreciate Mr. Hildreth, Dr. Hildreth, and Dr. Webb hammering that out, because I know it was a news item for a while. And that, we've been the index teaching hospital for Mahari for a long time, and hopefully we'll continue to be that for a long time. So then the last page is just a detail on the budget, but certainly I'm happy to answer any questions. We're projecting roughly an 8% growth in the inpatient volumes next year versus this year. A lot of that is in interventional cardiology and general cardiology, the new general surgeons we've added. And it may not be obvious to everyone, but we do a significant amount of business with the State Department of Corrections. We have a locked floor on the 7th floor of the hospital, and it is Centurion manages that contract on behalf of the state. They bring their prisoners in from a variety of locations. It's a good payer for the hospital. We take good care of those patients. We treat them just like anybody else. I mean, they're just as entitled to care as anyone else. We do a really good job with them. But they really cut off their referrals other than seriously urgent issues because of COVID. because they couldn't send multiple people in the van at the same time, particularly if there was rule out. And so that's had a significant impact. We do think that'll return, and the fact that we've got a lot more of the specialists that they've been asking us for quite a while means there's a good possibility that we're going to have a much busier 7th floor, and that's an excellent payer for the hospital. Helps keep the subsidy down. Yeah, I think that's really it until questions. Happy to answer.
Councilwoman Allen?
Thank you, Madam Chair, and thank you, Dr. Webb and Mr. Nairmore, for being here and going through all this with us. Two questions. Do y'all, I mean, you've said you haven't heard anything about CARES Act funding. Does that include the American Rescue Plan funding as well? Is there any expectation that that might come through for you?
Anything is possible. We rely a lot on Tennessee Hospital Association. Dr. Webb's on the board of American Essential Hospitals, so we kind of have a good ear on whether there's anything forthcoming. It's always possible, but we have no knowledge at this point of anything really in the works, unfortunately.
So nothing you can budget?
Right, but could I just say, because I know I've got Tom back here, but the other is, Tom will tell you that we have no cash reserves. If we get towards the end of the year and we got some money from CARES Act or some other, we just don't ask for the draw. So if we don't need it, we won't ask for it. And so they don't give me $48 million and say, go to town.
Gotcha. Okay, fair enough. And then second question, do you have a feel for sort of the long-term trend of the subsidy? I mean, in the long run, do we expect that to hang around 43 million or to hang now at the 49 million, or do you have a trajectory?
Yeah, and my personal is that it's a slight grade up. It's just, you know, last year's budget was, I'm not picking on anyone, nobody knew what was going to happen, right? And so I think everybody was happy and lucky to just get what you got the year before. But we had asked for 46 last year. So, you know, in the year before, I think we had asked for 44.9 or whatever. And we get to the end of the year, and I know Tom and crew, they have to move monies around too, which probably none of us want to see all that work that goes on to make sure they have cash in the right funds. So there are years where we've been short or we've been cut short a little bit. And that's just robbing Peter to pay Paul. It doesn't matter if you give me 44 this year, but I needed 46, then I'm starting 2 million in the hole the next year. We don't have any cash reserves. I've got no ability. So then you read about us in the paper because our accounts payable are up to 80 days. We're not playing with the money. We tried. I mean, I can promise you guys, I spend a lot of time looking to see what can we do this week, who can we pay. It's unique. And the city works very carefully with us. We talk every week, and they review with me where we are with our vendors and payables and so forth. So we're not an agency in the traditional way that some of the other agencies are. We're a mix or a hybrid. And so we have to be real careful with the way the money comes in and how it goes out.
Let me give you a little bit of the CEO version of that. Of the answer to your question. The reason that we have sought to venture into other areas of the city, particularly on Charlotte, was to attract a larger portion of individuals that have the ability to pay for their care. And with that, if we continue to move forward, we have the Bordeaux facility that will be coming online in February. That will also be a focus on an insured population. The strategy here is that if we maintain and continue to keep our patients that have been in that indigent care category and who historically have consumed large amounts of care, what we've been able to do is to reduce that. The high acuity patients that sought multiple visits in our emergency department has dropped dramatically. And that's not necessarily related to the national drop, but related more to proactive care for that population. So if we're keeping the care down and keeping that population healthy and growing the population of insured patients, that strategy is what we're deploying. And that should, if not stabilize us, should move towards less and less dependency on external dollars, so that we will be able to, as we continue to generate more on our own. So that is the strategy, and that's why we wanted to move forward with these providers, so that we could attract every individual in the community regardless of their ability. But we have not seen a large growth in the indigent population. That's remained stable. We don't turn anyone away. Right. It's just stabilized. But the growth that we've seen in our population and our volume has been insured patients. So we expect to see that trajectory continue as long as we're able to properly service that population.
Great. Thank you for that clarify. And thanks for all y'all do. It's such an important thing for our city to have.
Thank you, Mark.
Councilman Bradford.
Thank you, Chair, for recognizing me. I don't have the budget presentation in front of me, so I was wondering, how much have you budgeted for services like public relations, lobbying? Because earlier this year, there was a story that came out that the hospital is looking at spending $900,000 on those services. So I'm just wondering, did that get put in the budget? Are you planning on spending $900,000 on that, or what is your number that you're planning on spending?
I'm going to let Dr. Webb answer the question about government relations and all that other sort of things.
You can give him the amount.
Broadly, it's about $850,000, so your numbers are not far off. But it's been more in the past. It's just how is it distributed, I think, is always a question that comes up. We don't do a lot of marketing like on the television or something like that, just because it's expensive. And so we tend to do a lot of social media marketing and direct marketing. And then we do a lot of marketing to Metro employees, because we have a nice incentive plan for Metro employees. Basically, if they see one of our providers or come to the hospital emergency room and they have Metro insurance, they have no out-of-pocket expense whatsoever. So it's a nice incentive. But yeah, we spend on average $850,000, $900,000. It was higher when I first got here. It's a little bit lower currently, just because we've had some tough budget years.
Well, it is. It's actually a pretty good amount lower than what it was 2 to 3 years ago. But the services that we're getting from the vendors that we're using is much more effective. So it's much more of a targeted approach. And the term lobbying has been used a lot towards the services that we have in the marketing and public relations department. I suppose that's an appropriate term, but hospitals are always going to have some form of government relations resource that helps to keep them informed as to what's going on with policy, and trying to help to influence and get out in front and educate policymakers regarding what's actually taking place in the healthcare environment, because they rely on that. And if you don't have that resource, then you leave it to the policymakers to come up with their own solutions for you, which is not a good thing to do. You need to interact and make sure you're sharing information. What I call it is basically just stakeholder engagement, and making sure that all parties are involved and informed as to what's going on in the hospital. But we have not increased our budget for marketing and public relations, even though we do now have a chief marketing officer who is very well informed as to the proper protocol for how that division should be run.
And any of these services, are they done in-house, or are they done through contractors? If they're contractors, do you go through a bidding process?
It is actually both. Some of the services are in-house. We have a staff there in-house. We did the marketing firm that we use. We did bid that, and so yeah, it did go through that process.
Thank you. And one last question. You were talking about how some years you start the years already behind. And the same story that I was talking about, the expenses for marketing, talked about how you were behind on utilities, or was trying to get caught up on utilities, and behind on parking with Mahari. where are you at right now as far as, are you still behind on payments? Or are you kind of caught up? Or are you in a position where you think you'll get caught up pretty soon?
I should make Tom answer this question because he's sitting at his computer. But honestly, Councilman, as of today, I can tell you that we don't have one vendor that's outside of 60 days. So my goal since I've gotten there is to try to keep us in that 50 to 60 days from date of invoice. And, sometimes we don't get an invoice for 15 or 20 days. So we try to pay on time, and I will not allow late fees. Unfortunately, Mahari is one of my biggest, contracted providers. And sort of there's a few that are fairly significant, like our emergency room providers. Those are the ones, unfortunately, that get leaned on sometimes because they're big and we're going to be doing business with them for a long time, and they are actually fairly accommodating and know that we're going to pay them as soon as we get enough cash to do it. We're not going to leave anybody on the way, on the side. So there are times, because we have no cash reserves, that we just have to delay payment terms. And if they're big providers, and Mahari usually knows too, it's not like it's a secret. We know that they're behind, and we have conversations to say, as soon as we get enough cash in, we'll take care of you. But that's kind of a weekly challenge for us to stay up. Last couple of months, we've made a lot of dent. We were probably around 85 days outstanding accounts payable. Today, we're probably about 55, 56, which is where I would like for it to stay. It's a fair question. Thank you.
Thank you for that answer, and I appreciate your time here tonight. Thank you.
Thank you, Russ.
Councilwoman Henderson?
Thank you. Dr. Webb, Tennessee safety net public hospitals were featured last week on Frontline. Just generally talking about kind of the dynamics of the hospital supplemental pool and the share of funding, and how this is a nationwide problem, also particular to Tennessee, lack of Medicaid expansion, et cetera. Can you speak to, in your presentation here, you're talking about kind of other governmental funding. Do you have any forecasting kind of with this administration about what the hospital supplemental pool might look like? I mean, do you get guidance on that prior to putting your budget together, or do you just make assumptions based on the previous year? Can you speak to that space, Sam?
Yeah, actually, that's probably a better question for Bruce. He does deal with that issue.
Yes, sir. Thank you.
Yeah, I actually did speak to the people, I think it was an NPR report, and I actually participated with them, as I think they talked to all the public hospitals, not just us.
Oh, yes. To be clear, it was not, I think people hear Frontline. I mean, it was talking
Right.
nationwide about public
was.
hospitals. I'm sure you were interviewed here locally, so it was not negative towards you all. It was just speaking to the challenging environment.
I think, Tennessee has a unique approach, and it's been in place for 7 or 8 years now, where there's a pool. The pool has been $100 million for 8 years. So the pool is a fixed amount. And between Nashville General, Regional 1, the Med, and Erlanger, they distribute that $100 million according to the amount of uninsured and low-income care that's provided. Well, the amount that we provide, all of us, keeps going up, but the $100 million stays the same. So the proportion of what they're covering obviously goes down.
And so why is Nashville General only getting $10 million of $100 million?
Because they do it based on scale, and Erlanger and the Med are significantly larger. So if I do 500 low income, they must do 5,000 low income. And I never see their numbers, only the people at the state see that magic algorithm. So I have to take their word for it, and I'm sure they have no reason to do otherwise. But it's proportional to the amount of indigent care that each of those facilities provides.
Yeah, some national folks, I guess, spoke to it being kind of a black box somewhat as to the funding model. There's a certain lack of transparency there.
It is.
And so is that entirely kind of federal pass-through to the state, and then the state comes up with a model to disperse it? Or is there
Yes.
anything coming out of the state budget particular to safety net hospitals.
Yeah, I would have to defer to the state comptroller on that, but I will tell you just in other states I've been in, I don't think this one's very different. It's federal funds that make up that $100 million, but the state actually has to apply for a waiver to get those funds committed to this purpose, and then they set the rules, and CMS or others would have to approve of the plan, and I think they have for 8 straight years approved the plan. The issue is not that the plan is bad, it's just that the pool has been fixed for 8 years now at $100 million, so we're fighting over the same scraps every year. And this state has not. Other states have expanded Medicaid, even Louisiana, where I'm from, which, at least as red a state as Tennessee, they did expand it for financial reasons and because it was humane. So they don't have the same issue there, which they did 4 or 5 years ago.
And then, so from a lobbying perspective, as we were touching on earlier, is there a national advocacy group for public safety net hospitals that's advocating on the federal side? And then are the safety nets in Tennessee advocating together for, I know many are advocating for Medicaid expansion, but could you just sort of speak to that?
I'm going to defer to him this time because he's on the board of.
I serve on the board of America's Essential Hospitals. It's an 11-member board. We have roughly about 350 hospitals across the country that serve as members of the association. And yes, their entire focus, they're based in Washington, D.C., and their entire focus is lobbying and working with policymakers to the benefit of the safety net hospitals. So.
And Dr. Webb, do you anticipate with this administration there'll be any movement? Your colleague shared 10 years at the same amount. Is your board optimistic about this administration as far as the federal pass-through that'll be designated?
There's a lot more activity, engagement under this administration, the federal administration, than previous years. There have been some, the 340B program, for instance, the pharmaceutical program, has finally gotten out from under some of the fire that it was under and being reduced. So they're making some significant headway with the policymakers that are in office under this administration. So we're very optimistic about the headway that we can make.
All righty. Thank you so much.
Thank you.
Councilwoman Gamble.
Thank you, Chair Toombs. Thank you all for being great stewards of our safety net hospital and doing things to cut expenses and increase patient services. You mentioned that you're projecting an 8% increase in patient services over the next budget cycle. Is that as a result of the new Bordeaux facility, or are there other patient services? And can you explain or elaborate on what kind of patient services you think that will increase?
I'll go with that one, just because, before COVID, we were on a path that 10% growth was what we saw the first 7 months of that fiscal year. So basically, I hit reset. We've grown a little bit in services. So I think, he beats me up because he says I'm too conservative, but that's my job, is to make sure there's enough money at the end to pay for the services that we do provide. So 8% is kind of, some people might think it's high, but I think between COVID sort of coming to an end, Centurion and TDOC volumes returning to where they were, I think that's a relatively safe bet that we can get an 8% admission. The one thing that worries me is the emergency room admissions continue to, emergency room visits stay low. And Vandy, everybody else is having the same issue. Emergency room visits are just down everywhere. Not just Tennessee, I'm talking nationwide. And that's probably good for urgent cares. I'm not sure if it's good for medicine, though, that's all.
Is that a result of the pandemic, you think? Okay,
I do.
So
I
that
think
may change.
it's a conscious decision to stay clear of people,
Strategically, we do have to pay close attention to things that will impact volume. such as having a designation for a level 3 trauma, which as a tertiary hospital, you would expect that you would perform at that level. So it's not unusual for a tertiary hospital like ours to have level 3 designation. It really speaks to the services that you provide, and that for those individuals that are moving emergency patients around, if you have that designation, then there's some assurance on their part, on the part of that designation, that you're going to be able to take care of a patient at a certain acuity level if they bring that patient to you. So in essence, it becomes a marketing tool as well as a care tool for caring for that population, and it builds a stronger relationship with the emergency vehicle drivers. So that is something that we're making application to, and that's also a part of the structure that's in place with our providers, is to make sure that they are in place to care for that population. We anticipate that will generate additional growth. It's just one of those strategies that I normally don't get into in this setting, but since you asked that question, we're thinking a little bit longer term than 1 year, and a couple of years down the road, as we've made a prominent impact on this community as a level 3, as an organization that can take care of patients at that level 3 trauma acuity, then that's going to build more reliability for our organization as well.
Councilwoman Porterfield.
Thank you, Madam Chair, and thank you all so much for this wonderful presentation. I had a few questions that were actually in the slide here that you all covered in the slide, so I don't have to actually ask them, so thank you so much for that. I really wanted to highlight the appreciation for letting us know that you all have had those clean financial audits for fiscal years 18, 19, and 20. I think that's really important to highlight. I think, you know, when we are investing in various agencies, people want to know that there's a good return on their investment, and they want to know that these entities are being fiscally responsible. So thank you all for doing that. One question that I had from a previous presentation was about the skyrocketing price of contract nurses and having to contract out some of these services. But I see in the presentation that you all have backfilled some of those services and were able to fill some of these positions, which will ultimately cut down on the cost. So I definitely see ways that you all are just really trying to be very responsible with that. I know one push has been on trying to attract more insured patients to help bring up revenue costs. I've said it before, I'll say it again. I switched my services to general because I believe in what you all do, and just going and seeing, going on that site tour and seeing just all of the services that you all provide and how you go above and beyond for the preventative care to help cut costs in the long run, right? If you meet a person's care, then you're not servicing them in the emergency room, which is a higher cost. So I definitely appreciate like all those proactive services, and I encourage my colleagues, if you haven't gone, to definitely tour those facilities. And if you haven't considered it, to consider switching your services over, because this is top-notch, top-tier service. So thank you all for that. My question is, can you elaborate a little bit more on some of the additional recruitment that you all are doing to get more of those insured patients in? I know you talked about like moving the facility, opening the new facility on Charlotte, which is a gorgeous, top-notch facility. Absolutely love that facility. And that's one way that you all are trying to get more insured patients. Any other pushes, especially to try to get Metro employees to go, since there is such a savings to Metro employees by switching their services over? Do you all have any other pushes that y'all are doing to try to get more of those insured patients?
Okay, so right now, one of the probably more urgent items on our agenda is streamlining our access process so that it makes it very easy for individuals to access care at Nashville General Hospital. So we're working with a major team now to put that into place so that it will be extremely user-friendly, I should say. Now, in addition to that, the facility in Bordeaux will also have imaging services, and so that's a major revenue generator. And so with that, those individuals will not have to leave that community to get a CT scan or an ultrasound or some of the things that they will need. That's going to be a multi-specialty facility similar to Charlotte, except on a larger scale. Bordeaux is a healthcare desert, and so we'll be the first to open any kind of major healthcare facility in that community. So we're looking forward to the growth and development there. We believe that that will also be a major contributor to growing revenues as we move forward through the next year. So actually that will be later this fiscal year that it will actually open. And I could go on, but you probably don't have enough time.
Thank you for sharing that, and
Okay.
that is huge to hear about their Bordeaux facility. So that's really great news. My last question: some of my colleagues and I have kind of asked this to some of those other departments. When we hear about, what is being asked, the level that you are funded currently, is this meeting the need that you all have? I know, of course, if funds were unlimited, we all would like more funding, and there are a million things that we all would like to do. But are you funded in the proposed budget? Are you funded at a level to meet, to operate in the way that you all feel like you need to operate? Or are there some just really dire things that you all need funding for that hasn't been included in this budget?
Now, that's a great question. Actually, the operating budget itself, this is what we requested based on our projected expenses and associated costs. What we don't have is capital. And in my report, I stated that when a hospital has to use operating funds to purchase major capital equipment, it becomes a major drain on its operating dollars, and that puts you in a deficit. So what we would like to see is that there be more consideration given to our ability to acquire and maintain capital equipment. There is a phrase in healthcare and many industries called age of plant. And it's based on depreciation. It's an algorithm based on depreciation and costs associated with that. So we're running a very high age of plant, which means that a lot of the equipment and technology that we have is older. We do need to catch up. These funds that we got that I thanked you for early in my presentation were very helpful, and they went to the most urgent of equipment. But in all consideration, we would like for this body to consider providing more resources towards capital improvement in the hospital, because we are taking care of patients, and some of the stuff is very sensitive. And once it reaches a certain life span, it's not as reliable. But we maintain our equipment very well, and things work out for us. But we would love to see more capital going to the hospital.
Is there a number associated with more capital? Is there a specific number asked?
We always have a number for capital. It's a running number that we keep, and it's based on priority or need. And some of it happens to be regulatory. Some of it is more clinical. But we always have a number that's a capital listing of the equipment that we have. When we got this last capital from the administration and the council, we plucked the top most urgent items that we needed, and we still have a remaining capital list, so we can share that with you at any time.
I think that will be very helpful for myself and for my colleagues. Thank you.
Thank you.
Councilwoman Evans and then Councilwoman Hurd.
Thank you. I guess dovetailing into everything that you just shared, when I was there for my tour, one of the things that stood out was not having 3D mammography for women? And I wanted to know, in the last year, has that changed?
I don't think that's changed.
No, it has not changed. That's a pretty expensive piece of equipment, and just in the great scheme of things, it's not been one that got funded. You know, the million, just to give rough numbers, we got a refurbished CT so that we'll have a second CT machine at the hospital, because previously, when the one went down, and it's 8 years old, so occasionally it goes down, it's been a fantastic piece for the hospital, but when it goes down, we go on ER diversion, because you can't take care of a head bleed or these others that need to be diagnosed in that setting. So that's the good side, is that we bought some really critical things, a second angiography suite, which is a refurb, so that my interventional radiologist can work 7 to 3, just like my interventional cardiologist. They don't have to fight over the same cath lab. So those are really critical. We really needed those, but do I really need a 3D mammography? I promise you that most ladies are asking for it when they see their primary care physician. They are. So there's several of those things, Council Lady, but we don't have it yet.
Okay.
It's on the list, but it's not real high on the list of things right now.
Sure, I understand. Thank you.
Okay.
Not because we don't want it or
Right.
need it.
Right.
Okay.
Councilwoman Hurd.
Thank you very much. So I attended the benefits board last week, and its chair, Edna Jones, said that she had come to the hospital, and I was very happy to hear that, being that it is my preferred hospital. But the one thing I was wondering, and she also mentioned the Charlotte location, is Nashville General listed as a Tier 1 or Tier 2 provider on the Metro plan, and knowing that we're getting a new Advantage plan, are we listed on there? And if not, would that be helpful? Could that help save money or drive revenue or something?
It would be very helpful to be listed as a Tier 1, Council Lady Hurt, just because it gives, and it doesn't say that we're better than anybody. That's not the point. The point is to make sure that the Metro employees and their dependents understand that if they go to this hospital, they get the maximum level of benefits with the least amount out of their pocket. And I'll also say the hospital, our rates are a lot cheaper than sort of our peers. So not only does the city get a good break on what they pay for the insured portion, but the employee doesn't have to pay a copay or a deductible. So, but no, we're not listed any differently yet. We've run into roadblocks, just trying to get that sort of put in place.
So is it anything that we can do as a council to help that? And would that also help with ancillary services?
Absolutely.
Or, I mean, just trying to get a little bit of understanding, you know, with the limited knowledge, you know, thinking that was a possibility.
Yeah, it would certainly increase the ability for Metro employees to access the hospital and have clarity in how their pocket's going to be impacted. We could do a much better job of promoting that to them, because it's been in place for a while, but there are some barriers when you're not listed as a part of the Tier 1. And so that would be very helpful for us too.
Because just to give you, for people that have insurance, you know, that they know how that works. The way it works now, if you're a Metro employee and you come to the hospital and you are covered by Blue Cross and you have a $1,000 bill, if your copay is $100, we don't ask you for it. But when you get the claim EOB from Blue Cross, it's going to say you owe the $100, because it's really not loaded into the benefits. That's what the Tier 1 would do. It would load that deductible and copay into Blue Cross and Cigna, so that you don't get a surprise. It may, you think, and then you call me and say, you said I didn't owe the $100. And I said, you don't. But we have to fix it on the back end. And that always makes people feel uneasy about it the first time they use it. So it takes faith.
Yeah, so whenever we promote the plan to people, which is why we hold back some, whenever we promote it and then that happens, and then they're calling Bruce and his people saying, hey, wait a minute, what are you doing? I thought I didn't have to do this. So what we're trying to do is to to create more clarity and transparency in that whole process so individuals don't feel like they're getting duped into coming to the hospital, and now you're sticking me with a bill. And they get angry. They really get angry about that, and I guess you would too.
So I guess that's a question for Director Cooper. Is it something, or what can we do as a council? Do we need to reach out to the Benefits Board or HR to see if there's a way to get this designation as a Tier 1 provider on the insurance?
That would be a question for Shannon Hall. We can reach out to her. I'm not familiar with that process, but we can certainly reach out to her to check on that.
Thank you. I'd appreciate that.
Thank you.
Dr. Webb and Mr. Nairmore, you mentioned the increase in your number of insured patients. What's the source of those patients? Are they coming through the ER? Are they coming to your clinics? Are those inpatient stays? Where are you seeing that increase in insured patients?
The majority of the net new sort of, our insured, uninsured has moved from it was around 50-50, probably 2016. Now it's around 62% insured, 38% not insured. In the clinics, the insured population is higher. In the emergency room, it's pretty close to that 60-40. But the strategy is obviously to get out there away from the hospital. Some people just don't like to come to hospitals. They don't like to have to park. They deal with all those issues. So we're trying to go where the patients are. If they need something significant, we'd refer them into the hospital, of course, for service. But it's about our clinics are probably 70% insured, so it's a little higher. But for some of my clinics that are located at the hospital, it might be 50-50. And that's where, in fact, like an internal medicine clinic that's run by the Mahari faculty and their residents, that one's probably about 40% insured and 60% uninsured. But most of the clinics, certainly the ones out at Charlotte, are probably 95% insured. And we believe the same will be true at Bordeaux. People have a very odd appreciation of Bordeaux. I'm an old insurance guy too, not just a hospital guy. Bordeaux is a very well-insured community. And this hospital has a very low cost profile, so we can actually make money on Medicare and Medicare, Medicaid patients, which a lot of big providers, they don't particularly care for that. They'd rather get the fully insured patient in their location. So that's where we're going. We're going to the patients. There's not a lot of providers out in the Bordeaux area, and we think that'll be a quick strike, and it'll be busy early on.
So strategically, the application of outreach was applied through Charlotte. If we had remained just on the campus, we probably would not have seen this growth. In order to be a viable competitor, which many don't see the hospital as being a competitor, but if you're looking at the same patient population as someone else, then essentially you're a competitor. You might not be a large competitor, and I don't see us as being a threat to the big three, but we do need to be able to gain access to patients that are paying patients so that we can offset some of the costs that the city and the taxpayers put towards covering this population. If we can get to a point where we could substantially reduce that, the benefit doesn't go to a shareholder, it goes back to the city. And so that's the equation that we work with. We realize that if we are off the campus and out in the community, we call it our outreach strategy, then we're going to be able to bring more people to the table who are paying for their care. And that's the equation that we're looking for. And this number that we're seeing with growth in insured patients is not by accident. It is really genuinely based on a strategy that we've deployed.
And so my last question in regard to the subsidy for this fiscal year, 21, do you anticipate using the total amount of the subsidy that you received, or do you anticipate having any funds remaining?
At this point, I think Tom could confirm, I think we've requested the last of the subsidy sometime end of May, early June, so we will have absorbed the whole 43.
All right, we are at time, and I am looking across the room to see if there are any final hands. Seeing none, thank you, Dr. Webb and Mr. Nairmore, for your time.
Thank you, Council.
Thank you all.